question.
And we're looking at hypertension being 140 over
140 over 90. Kidney labs? For this, they may not be effective yet. And we try and keep them from not being. Okay, so this gestational hypertension thing, it's fairly common. It affects about 12 to 20% of all pregnancies. It is the second leading cause of maternal death in this country. And again, we don't know what it is or why. We kind of can describe what happens, but we can't say exactly what causes it. Here are some of those risk factors I was mentioning about. These people may be a little bit more prone to it. Chronic renal disease, chronic hypertension. So women come in with some disease processes already, chances are they will develop the gestational hypertension, preeclampsia. So interesting there, we were talking about genetics. Both of those can have a genetic compound to heart disease and kidney disease. And here again, now it's reaching into our pregnant women. Family or personal history of preeclampsia. If she had it in her first pregnancy or second pregnancy, she's really more at risk to have it with the next pregnancy. Her family history of blood female relatives, her mother, her sister. Multiple gestations. Here we've got more babies, which is more placenta tissue, so she's at more risk. Right. Prima gravida, for some reason, having her first baby, she's more likely to develop this. And then, as Jennifer mentioned, the age extremes. If she's a very young mom, or if she's on the older scale, both of those populations are more at risk. Jennifer, do you mind saying a few words about your patient on Monday?
A 14-year-old who did not have a history of hypertension when she came in. She was in active labor, and within a half an hour, her BP went up to, it was like 109 over 78 normally, and then her BP went up to 145 over 91, and the nurse immediately, she had blurred vision, and she was starting to have some edema. It was very difficult to draw blood on her. So
And why would
now
that
that
be?
the coagulation of
And what else?
the edema is
And what
making it
else?
smaller to her
It's
age,
constricted
smaller
vessels.
vessels.
The constricted
Yeah.
vessels. Right. Yeah, horrible person to have to get blood from.
And we, the labs went down stat, which is also, you don't have to wait for a doctor's orders on that.
Did she have prenatal? Did she have prenatal care, Dominique wants to know?
Yes, she did. She had private care, so she wasn't seen through the clinic. But it was an interesting dynamic in the room. She had family in there, but they weren't helpful or really like psychologically supportive with her. They all stood in the back, went to go get food. When she was going through her contractions, I was holding her hand, not her mom. So it was just,
Right. Did you have access to her pregnancy visits to see where her blood pressure ran?
her blood pressure had always been in the normal range prior to that.
So again, our typical candidate for preeclampsia. Diabetes puts them at risk, as does an RH incompatibility with the infant and obesity. So those symptoms are kind of all over the place, but you can kind of see where they might point to protein in the placenta of some sort. Okay, let's try a pregnant client is admitted with preeclampsia. The condition is most often manifested ball-like. Hypertension occurring during the first. So I mentioned that we can diagnose preeclampsia with either mild or severe, and again, it just depends on the values of your assessments. So with mild, we're going to stick with that 140 over 90 blood pressure. We're going to get proteinuria that could be 1 or 2 plus. Here's our mild to moderate pretibial edema, and then a 2 to 2.5 pound weight gain per week. That's a lot of fluid. Then, if things like that increase in severity, we're going to label her severe preeclamptic if her blood pressure is greater than 160 over 110. If her proteinuria jumps to 3 to 4 plus. If she has a sudden large weight gain, larger than the 2 to 2.5 pounds a week, with the facial edema, the pitting pretibial edema, her reflexes are hyper. Possible clonus. Who can tell me what clonus is? It's a neuroinvolvement, but it's not a seizure. Anybody else? It's an assessment technique, and we're looking for the result of clonus possibly. Hmm? Twitching of the dorsal reflex. So if you, like we did the Homan sign, you've got her laid out in bed or on a flat surface, and with the Homans, we just kind of slowly dorsiflexed her foot back towards her head to check for any pain under here. Well, this one, we don't slowly do it, we jerk it back very quickly. So you jerk it back, and if it twitches, that's clonus. And if it twitches, we count the number of twitches, and that is the beats of clonus that we have assessed.
The foot twitches?
The foot twitches. So you elicit a twitching behavior, and the number of twitches is the number of beats of clonus, and obviously the more beats, the more severe the problem. So you might read in your assessment she had 3 beats of clonus on exam. And again, that's a sign that her neurosystem is having an effect from the preeclampsia. Yeah.
Just here or?
Pre. It's the lower leg.
Oh, the lower leg.
Right, and we usually check our edema up there because you have a nice bony surface underneath for pushing things. Now checking edema back here is helpful. So yes, that means the lower leg down there. So which is why checking her reflexes when you're doing your exams, nobody seems to do it labor and delivery, but on postpartum, we should include that as a part of our bubble assessment because that can be your first warning sign that she is getting into problems. And this can all develop after she's had the baby. Even though the placenta's out, she can have a resolving seizure, or she can develop an increase in her blood pressure and some neuroactivity. Remember, we really want to avoid that seizure. So an indication that her neurosystem is compromised will be hyperreflexia and clonus. And then we've got the headaches and the visual changes. But it's very simple to take a reflex hammer and be assessing her while you're caring for her. Intrauterine growth restriction, oliguria. Again, the kidneys are not having perfusion. Yeah, Jennifer.
Is the IUDR as a result of that? The uterus is not getting enough diffusion?
Exactly.
So it's just kind of shrinking?
Well, a baby can't grow without oxygen. So if it manages to grow and not die, it's going to be a smaller baby, it's going to be a compromised baby. But yeah, blood is just not getting from the uterus into the placenta.
In that IUDR without having?
Absolutely, because of different things. And then there's cerebral and visual disturbances we talked about again. Constriction, blood is not getting where it needs to go. Systemically, that's where we see the headaches, the visual disturbances, the epigastric and the right upper quadrant pain. We need to pay attention to these women when they come in and they have pain in this general area, because what we're worried about is that liver rupture. So if she says, I have heartburn really bad, can I take some Tums? And she's 38 weeks. Do we really think we should just say over the phone, sure, take some Tums and feel better? No, because it could be the beginning of something. It could be heartburn, but it's probably something that we should see her, maybe get some coags, maybe check for edema, blood pressure, things like that. So we'll find that there are a lot of things we tell the moms to call us about. Remember back in the first week, call us for headache, call us for vomiting, call us for this, which seems kind of, this is why. All those symptoms could be the beginning of something very, very serious. Morbidity, maternal, we mentioned we could have cerebral hemorrhage, the vasoconstrictions, the decreased platelets, bleeding, rupture of the liver, renal failure, rupture of placenta, retinal detachment, cardiac failure, death. Very, very serious, very serious. You're going to talk about a rupture of placenta, but we had a case this week in clinical where the mom was 39 weeks and 6 days. She did not feel the baby the night before, so it had been Sunday night, she didn't feel the baby. She started to bleed Monday morning, came into the doctor, and the baby had died. And as they were assessing what was going on with her, her abdomen was just getting bigger and bigger and bigger and bigger. So they went in and they did a cesarean, and she had erupted and her abdomen was full of blood. Now, I know nothing about the patient to know if maybe she would be getting preeclampsia. I don't know that much about her. very, very fast, sad situation, and the cause was abruptio placenta. So if we catch this early, if we catch that beginning blood pressure or that beginning proteinuria, we may be able to prevent some of those things. Yeah, Erica.
When we took her history, she said she had to stand that blood pressure.
Erica's saying when she took, because Erica worked with her, when she took her history, she did have a history of high blood pressure. Now, abruptio placenta is very serious, and I think the fetal mortality is about 20 to 40%. So it's serious for those babies. But this baby had not been dead very long, so obviously within a 12-hour period. So again, your assessments can really ward off some of these things, and your education to the moms. I know when I was having my kids, and my youngest is 22, they never taught me about counting movements or counting kicks. Never taught me. Anybody else here that got taught? You didn't get taught?
I was.
No, I didn't get
Were
taught
you?
that.
I was, and my youngest was 21,
Okay.
and I have a 28-year-old.
Okay. The neuro involvement here, we're gonna really try and keep her neurosystem quiet. In fact, when you learned about seizures and convulsions, quiet environment, dark environment, not a lot of activity. So it really depends on how far along she is, to what degrees we need to go. Yeah. So, it'll depend on how far she is and how severe. And the only way to fix her is to get the baby out. So, no problem for a 39-weeker, getting the baby out. What about a 22-week? That's a little bit different decision. What about a 35-week? Probably survive, may have some issues. So, this is becoming a very, I don't know, difficult decision. The more we know about it, the earlier we're detecting it. That's a heavy thing to come to a family at 23 weeks and say, we need to have your baby out to save your life. You know, you see the movies back in the Westerns and things like that, we're gonna save the mom or the baby. It happens. It's still a decision that has to be made every day. And it will probably involve the ethics committee, depending on a hospital or whatever, because if you're delivering a baby that you know will not survive, that's a heavy decision. And some parents don't decide to deliver the baby. All right, so we want perfusion to increase. We're gonna decrease perfusion. So of course, we're gonna go for the left side position. Get as much oxygen to that baby and to mom's major organs as possible. Keep it quiet. This isn't the room to have dad come in and watch the Super Bowl with his buddies, keep her company or anything like that. We wanna kinda keep it quiet. We're gonna do frequent assessments. Obviously, all her major vital signs, anything else that we wanna track, like her edema and her reflexes, we're gonna keep assessing those so we can catch anything early. And then if she's in the hospital, or even if she's home, she may have a Foley with home care. Put a Foley in there, again, to make sure that we're getting enough output. Now, some of this could be done at home, and some could be done in the hospital. It depends, A, on the severity of her illness, and B, her cooperation with her plan of care. Because a lot of this, the high blood pressure and the edema, she's probably not having any pain. She may not even be having any symptoms to complain about. So she comes in for her 7th-month visit. Her blood pressure's up, she's got 1+ protein, and she's much more deficient. We say, Mrs. Smith, you need to stop working and go on bed rest for 3 months or 2 months. She's gonna look at us like we're nuts. Think if it was you guys right now, in the program. We planned it well, I'll deliver right after I graduate, I'll have a baby before I get my job. Well, no, you have to go on bed rest right now. But you don't feel sick. There is a compliance problem with these ladies sometimes. They may have little kids at home that they need to take care of. They can't afford to have a babysitter or something to take care of. So there's a lot of obstacles sometime in the way of people complying with this. So that will depend if she goes to the hospital. So if she's at home, taking her blood pressure, having the home care nurses come, we can even monitor fetal hearts through the phone now. We can really watch all that at home with a home care nurse coming to see her, if she'll stay in bed and she'll stay on her left side and she'll do what we ask her to do. If we come and check on her and her values are still kind of out of whack or getting worse, we know she's not abiding by the plan, and we will yank her and put her in the hospital. So again, it depends on the severity of her illness and her cooperation with care to determine when she will be hospitalized. If she is severely ill, she definitely is in the hospital, and anytime she is in ICU. She is hooked up to a whole lot of stuff, and they will more than likely take one of the labor and delivery nurses to be up in ICU, taking care of the baby part, with the fetal monitor, and assessing contractions if they're happening, something like that. So this mom, if she's severely ill and she has severe preeclampsia, more than likely could end up in